Hello and welcome everybody to today's Preventive Medicine Grand Rounds for October 4th, 2023. Today's session will be on the 2022 CDC Clinical Practice Guidelines for Prescribing Opioids for Pain by Kristine Schmit, a medical officer in the National Center for Injury Prevention and Control in the Division of Overdose Prevention. Continuing education will be available for this session. There will be information will be put into the chat or in the email announcements about the Preventive Medicine Grand Rounds. I would like to thank Dr. Schmit for her time to present today, and I'm now going to turn it over to her to talk about today's topic for the clinical practice guidelines for prescribing opioids for pain.
Great, thanks, Mike. And thank you very much for inviting me to present at today's Grand Rounds. I'm delighted to be here. Today, I'll be providing a brief introduction to the Division of Overdose Prevention where I work, and an overview of the 2022 CDC Clinical Practice Guideline for Prescribing Opioids for Pain, which was released in November 2022. To begin with, let me provide some background on drug overdose and overdose deaths in the United States over the past 2 decades. You've all probably seen this slide before, showing the overdose epidemic in the US. The epidemic unfolded in 3 waves, starting with a rise in prescription opioid-associated deaths in the early 2000s, followed by a rise in heroin overdoses about a decade later, and now a 3rd wave largely driven by synthetic opioids. Today, over 1.1 million people in the US have died from a drug overdose since 1999, and nearly half of those were related to opioids. Based on the most current numbers, in 2022, there were 109,680 overdose deaths. A growing proportion of all drug overdose deaths in the US involves synthetic opioids, as I mentioned, particularly illicitly manufactured fentanyl. However, there is also an increase in co-involvement of substances in overdose deaths. CDC's work in this area sits in the Injury Center within the Division of Overdose Prevention, or DOP, which was officially formed in 2019, although work had been going on in this area for much longer. The overall mission of DOP is to prevent overdoses and substance use-related harms. DOP's work is guided by 6 principles and 5 strategic priorities to address the overdose crisis. The guiding principles include promoting health equity in all that we do, addressing underlying factors of substance use and overdose, partnering broadly to increase reach, taking evidence-based action, advancing science around substance use and overdose prevention, and driving innovation. And our strategic priorities consist of monitoring, analyzing, and communicating trends in substance use and overdose, building state, tribal, local, and territorial capacity to address the epidemic, supporting providers, health systems, payers, and employers to improve care, partnering with public safety and community organizations, and raising public awareness and reducing stigma. The work across the division is extremely varied, but some examples of the work we do in DOP include data visualization dashboards like these to help understand the scope and trends of the overdose epidemic. 3 of these data dashboards collect data on non-fatal drug overdoses within the United States. Data from these dashboards come from separate systems, including syndromic surveillance systems, ED and hospital discharge data, and a 5-year study examining fentanylogs among non-fatal suspected opioid-involved overdoses. These data systems provide complementary information to understand non-fatal drug overdoses in the United States. The Suitors dashboard provides comprehensive data on unintentional and undetermined intent drug overdose deaths collected from death certificates and medical examiner and coroner reports. This dashboard provides annual counts, percentages, and rates overall and by jurisdiction. In addition, CDC provides alerts through press releases and health advisory network health alerts about emerging trends and substances of concern. A key activity overseen by DOP is the Overdose Data to Action, or OD2A, cooperative agreement, which supports jurisdictions in implementing prevention activities and in collecting accurate, comprehensive, and timely data on non-fatal and fatal overdoses. OD2A focuses on understanding and tracking the complex and changing nature of the drug overdose crisis by integrating data and prevention strategies. CDC launched the first multi-year OD2A cooperative agreement in 2019 with 66 recipients, comprising state, territorial, county, and city health departments. In August of this year, CDC awarded new 5-year cooperative agreements to 90 jurisdictions under 2 distinct OD2A programs, one designed for states and one designed specifically for localities and territories. OD2A is guided by a data to action framework as shown here. Data to action means using different types of data to select, improve, and scale up drug overdose prevention programs and policies. These data include surveillance data, process and outcome evaluation data, and data from partners, including those who use drugs or have lived experience with drug use. In addition, jurisdictions explore how they can use data from focus groups, community meetings, or partner interactions to inform or adapt surveillance data collection or analysis. At the core of this model is a focus on health equity and reducing health disparities by engaging partners and integrating people with lived experience into all components. Ideally, funded jurisdictions will be able to respond more quickly, more effectively, and more equitably to their constituents' needs, using data to drive action steps that reduce overdose deaths and substance use-related harms. And as I mentioned, in November 2022, we published the 2022 CDC Clinical Practice Guideline for Prescribing Opioids for Pain. These guidelines provide recommendations for clinicians providing pain care, including those prescribing opioids, for outpatients aged 18 or older. This would be the main focus of the presentation today. For some background about the motivation for creating the guideline, studies have shown that pain is one of the most common reasons adults seek medical care in the US, and that pain, in particular chronic pain, can lead to impaired physical functioning, poor mental health, reduced quality of life, and contributes to substantial morbidity each year. The purpose of guidelines like the 2022 CDC Clinical Practice Guideline helps ensure patients receive safe, effective pain treatment. Since 2012, opioid prescribing has been declining. While the release of the 2016 CDC Guideline for Prescribing Opioids for Chronic Pain was associated with an accelerated decline, opioids remain a common treatment for pain and continue to be dispensed. In the US in 2021, among persons 12 years and older who reported misuse of prescription pain relievers in the past year, 44.9% had obtained their pain reliever from a friend or relative, and 39.3% had obtained their pain reliever from a prescription from one doctor. In 2020, approximately 143 million opioid prescriptions were dispensed from pharmacies in the US. In the US in 2021, among persons 12 years and older, 8.7 million people reported misuse of prescription pain relievers in the past year, and 5 million had a past year prescription pain reliever use disorder. Prescription pain relievers remained the most commonly misused prescription drug in the US in 2021. And in 2021, persons 12 years and older who misused prescription pain relievers in the past year reported the following reasons for their last misuse. 64.3% reported misuse to relieve physical pain, 10.7% reported misuse to feel good or get high, and 7.3% reported misuse to relax or relieve tension. So I mentioned the 2016 CDC guideline, and you may be wondering why the 2016 guideline was updated. And since 2016, new evidence has become available on the risks and benefits of prescription opioids for acute, subacute, and chronic pain, comparisons with non-opioid pain treatments, dosing strategies, opioid dose-response relationships, risk mitigation strategies, and opioid tapering and discontinuing. This new information prompted the expanded CDC guidance. So the 2022 CDC Clinical Practice Guideline reflects the new evidence and research available and provides evidence-based recommendations for clinicians prescribing pain care, including opioid medications, for acute, subacute, and chronic pain for outpatients aged 18 years or older. It does not provide recommendations for pain management related to sickle cell disease, cancer-related pain, palliative care, and end of life. However, recognizing that all pain needs to be appropriately assessed and treated, clinicians are referred to existing clinical guidelines that more specifically address the unique considerations for the management of these conditions that lie outside the scope of the guidelines. The recommendations are designed to be flexible to enable patient-centered decision-making, taking into account an individual's expected health outcomes and well-being. The 2022 Clinical Practice Guideline provides clinicians with the information they need to discuss pain care options with their patients and to work with the patient to help them achieve their personal goals for pain care and function. More specifically, its purpose is to provide recommendations to improve communication between clinicians and patients about the benefits and risks of pain treatments, including opioid therapy for pain, improve the safety and effectiveness of pain treatment, mitigate pain, improve function and quality of life for patients with pain, and reduce the risks associated with opioid pain therapy. Now let's take a closer look at the 5 guiding principles for implementing the recommendations. Principle number 1, acute, subacute, and chronic pain need to be appropriately assessed and treated, independent of whether opioids are part of a treatment regimen. Principle number 2, recommendations are voluntary and are intended to support, not supplant, individualized person-centered care. Flexibility to meet the care needs and the clinical circumstances of a specific patient is paramount. Principle number 3, a multimodal and multidisciplinary approach to pain management, attending to the physical health, behavioral health, long-term services and supports, and expected health outcomes and well-being of each person is critical. Principle number 4, special attention should be given to avoid misapplying this clinical practice guideline beyond its intended use, or implementing policies purportedly derived from it that might lead to unintended and potentially harmful consequences for patients. And finally, principle number 5, clinicians, practices, health systems, and payers should vigilantly attend to health inequities, provide culturally and linguistically appropriate communication, including communication that is accessible to persons with disabilities, and ensure access to an appropriate, affordable, diversified, coordinated, and effective non-pharmacologic and pharmacologic pain management regimen for all persons. Before I highlight some of the new updates and key changes in the recommendations, I would also like to briefly discuss some of the information that has been retained. While reviewing the new research and evidence for the 2022 Clinical Practice Guideline, it reinforced the 2016 guideline recommendations for judicious use of opioids for chronic pain. Therefore, CDC retained the principles for prescribing opioids for chronic pain. These recommendations included maximizing the use of non-pharmacologic and non-opioid therapies, and only considering initiating opioid therapy if expected benefits for pain and function are anticipated to outweigh risks. And when opioids are needed, clinicians should prescribe immediate release opioids, initiate therapy with the lowest effective dosage, carefully evaluate individual benefits and risks when considering increasing dosage, and avoid increasing dosage above levels likely to yield diminishing returns and benefits relative to risks. Now I'll discuss the intended use of the 2022 Clinical Practice Guideline. This refers to the intended audience for the guidelines and healthcare settings. In this section, we'll also cover the conditions that are excluded by the 2022 Clinical Practice Guideline. The guideline provides voluntary clinical practice recommendations for clinicians managing pain in outpatient settings. Recommendations should not be applied as inflexible standards of care across patient population. And these recommendations are not intended to be implemented as absolute limits for policy or practice across populations by organizations, healthcare system, or government entities. The intended clinicians for the 2022 Clinical Practice Guideline include primary care clinicians, including family physicians, nurse practitioners, physician assistants, and internists. Clinicians in other specialties managing pain in outpatient settings, such as surgeons, neurologists, obstetricians, gynecologists, dentists, and other oral health professionals. Emergency clinicians providing pain management for patients being discharged from emergency departments. And physical medicine, rehabilitation, and occupational medicine physicians. The 2022 CDC Clinical Practice Guideline updated applicable healthcare settings to include clinicians' offices, clinics, and urgent care centers. It's important to note that the recommendations do not apply to patients who are being cared for in emergency departments, hospitals, or other observational settings. However, the recommendations do apply to prescribing pain management when patients are discharged from emergency departments, hospitals, or facilities. Now let's dive into the actual recommendations themselves. The 12 recommendations are grouped into 4 areas for consideration. Number 1, determining whether or not to initiate opioids for pain. Number 2, selecting opioids and determining opioid dosages. Number 3, deciding duration of initial opioid prescription and conducting follow-up. And number 4, assessing risk and addressing potential harms of opioid use. Recommendations 1 and 2 are focused on determining whether or not to initiate opioids. All patients with acute, subacute, or chronic pain should receive treatment that provides the greatest benefits relative to risk. When initiating opioid use, clinicians should only prescribe and advise opioids use as needed. Opioids can be used when benefits for pain and function are expected to outweigh the risk for opioid use. Before prescribing opioid therapy, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy. Whenever opioids are prescribed, clinicians and patients are encouraged to have an exit strategy in mind in case the treatment is unsuccessful in improving pain and pain-related function, or the risk for opioids outweigh the benefits. Recommendation number 1, non-opioid therapies are at least as effective as opioids for many common types of acute pain. Clinicians should maximize use of non-pharmacologic and non-opioid pharmacologic therapies as appropriate for the specific condition and patient, and only consider opioid therapy for acute pain if benefits are anticipated to outweigh risks to the patient. Before prescribing opioid therapy for acute pain, clinicians should discuss with patients the realistic benefits and known risks for opioid therapy. Recommendation number 2, non-opioid therapies are preferred for subacute and chronic pain. For subacute or chronic pain such as back pain, fibromyalgia, tension headache, and hip or knee osteoarthritis, non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred. Clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risk to the patient. And if opioids are used, clinicians should work with patients to establish realistic treatment goals and determine an exit strategy to discontinue opioid use if benefits do not outweigh risks. Recommendations 3 through 5 are focused on selecting opioids and determining dosages. I want to emphasize that the recommendations related to opioid dosages are not intended to be used as an inflexible, rigid standard of care. Rather, they are intended to be guideposts to help inform clinician-patient decision-making. Appropriate selection of opioids and dosage are important factors when opioid therapy is prescribed as part of a patient's pain management plan. Clinicians should discuss the benefits and risks for different types of opioids with patients. Recommendation number 3, when starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of extended release or long-acting opioids. Recommendation number 4, when opioids are initiated for opioid-naive patients with acute, subacute, or chronic pain, clinicians should prescribe the lowest effective dosage. If opioids are continued for subacute or chronic pain, clinicians should use caution when prescribing opioids at any dosage, should carefully evaluate individual benefits and risks when considering increasing dosage, and should avoid increasing dosage above levels likely to yield diminishing returns in benefits relative to risk to patients. Recommendation number 5, for patients already receiving opioid therapy, clinicians should carefully weigh benefits and risks and exercise care when changing opioid dosage. If benefits outweigh risks for continued opioid therapy, clinicians should work closely with patients to optimize non-opioid therapies while continuing opioid therapy. If benefits do not outweigh risk for continued opioid therapy, clinicians should optimize other therapies and work closely with patients to gradually taper to lower dosages, or, if warranted based on the individual circumstances of the patient, appropriately taper and discontinue opioids. Unless there are indications of life-threatening issues, such as warning signs of impending overdose, opioid therapy should not be discontinued abruptly, and clinicians should not rapidly reduce opioid dosages from higher dosages. In situations where benefits and risks are close or unclear, shared decision-making with the patient is particularly important. Some key topics included in the implementation guidance for recommendation number 5 include determining whether, when, and how to taper opioids, providing advice to patients prior to tapering, handling pain management during tapering, providing behavioral health support during tapering, deciding on a tapering rate, managing opioid withdrawal during tapering, highlighting potential challenges to tapering, and explaining the best way to continue high dose opioids if warranted based on the patient's clinical scenario. Recommendations 6 through 7 offer guidance on the duration of initial opioid prescribing and conducting routine patient follow-up. Clinicians should involve patients in decision about opioid duration. Duration should be individualized based on the clinical circumstance of the specific patient. Clinicians should regularly assess patients who are receiving ongoing opioid therapy. The suggested interval is every 3 months or more frequently, depending on the particular clinical scenario. During follow-up appointments, clinicians should ask patients about their preferences for continuing opioids based on the effects of therapy on pain and function relative to any adverse effects experienced. Recommendation number 6, when the diagnosis and severity of acute pain warrant use of opioids, clinicians should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. A few days or less are often sufficient, but duration should be individualized based on the clinical circumstances of the specific patient. Longer durations of opioid therapy are more likely to be needed when the injury is expected to result in prolonged severe pain, such as severe traumatic injuries. Recommendation number 7, clinicians should evaluate benefits and risks with patients within 1 to 4 weeks of starting opioid therapy for subacute or chronic pain or of dose escalation. Clinicians should evaluate patients with subacute pain who started opioid therapy for acute pain and have been treated with opioid therapy for 30 days to reassess the patient's pain, function, and treatment course to ensure that potentially reversible causes of chronic pain are addressed and to prevent unintentional initiation of long-term opioid therapy. Evaluation within the first 3 months or more frequently might provide opportunities to identify and mitigate risks for opioid use disorder and overdose. Assessing risk and addressing potential harms of opioid use are addressed by recommendations 8 through 12. Clinicians should evaluate and discuss a patient's risk for opioid-related harms before initiating opioid therapy. They should assess these risk factors periodically with frequency individualized to patient comorbidities and other risk factors. And they should create a management plan that incorporates strategies to mitigate risk, including offering naloxone. Recommendation number 8, before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk for opioid-related harms and discuss with patients. Clinicians should work with patients to incorporate into the management plan strategies to mitigate risk, including offering naloxone. In the implementation guidance, there's guidance for certain patient populations who may be at greater risk for overdose. Recommendation number 9, when prescribing initial opioid therapy for acute, subacute, or chronic pain, and periodically during opioid therapy for chronic pain, clinicians should review the patient's history of controlled substance prescriptions using State Prescription Drug Monitoring Program, or PDMP data, to determine whether the patient is receiving opioid dosages or combinations of medications that put the patient at high risk for overdose. Ideally, PDMP data should be reviewed before every opioid prescription for acute, subacute, or chronic pain, and then every 3 months or more frequently during long-term opioid therapy. Clinicians should use specific PDMP information about medications prescribed to their patient in the context of other clinical information, including their patient's history, physical findings, and other relevant testing, in order to help them communicate with and protect their patient. Recommendation number 10, when prescribing opioids for subacute or chronic pain, clinicians should consider the benefits and risks for toxicology testing to assess for prescribed medications and other prescribed and non-prescribed controlled substances that increase risk for overdose when combined with opioids, including non-prescribed and illicit opioids and benzodiazepines. Recommendation number 11, clinicians should use particular caution when prescribing opioid pain medication and benzodiazepines concurrently, and consider whether benefits outweigh risks of concurrent prescribing of opioids and other central nervous system depressants. And finally, recommendation number 12, clinicians should offer or arrange treatment with evidence-based medications to treat patients with opioid use disorder. Detoxification on its own without medications for opioid use disorder is not recommended because of increased risk for resuming drug use, overdose, and overdose death. Implementation guidance for recommendation number 12 includes additional treatment guidance for management of opioid misuse that does not meet criteria for opioid use disorder, and pain management for patients with opioid use disorder. So that is a very brief overview of the 2022 CDC clinical guideline for prescribing opioids for pain. With the recommendations that I just highlighted here and the guidelines themselves, each recommendation also has implementation considerations. They go into more detail about how to think about the recommendations and how implementing them in practice would look like. So I strongly encourage you, if you have a chance, to take a look at the guidelines themselves. There is some a rich wealth of data in there supporting the 12 recommendations. But I would also like to highlight some resources that you might find useful in addition to the guidelines themselves. So first, DOP's communication team has created new web pages specifically highlighting the new guidelines. And I want to highlight a few more newly developed web pages on the CDC website. As you can see in this picture, these pages are more topic specific and provide additional guidance and considerations for clinicians when initiating opioid therapy, continuing opioid therapy, and preventing and treating opioid use disorder. Later this year, we'll also be posting new web pages on non-opioid therapies, dental pain and opioids, opioids and pregnancy, and guidance for healthcare administrators. To assist clinicians with understanding and implementing the 2022 clinical practice guideline, we've also developed new interactive training modules. The new guideline overview module will include patient scenarios, knowledge checks, tips, and other resources. In recognizing how busy clinicians are, the training module is self-paced, and clinicians can earn free continuing education credits for the training. Some other resources on CDC's website include the Addiction Medicine Toolkit, which is an introductory overview of addiction medicine for primary care clinicians and includes an addiction medicine primer, checklist, conversation starters, and interactive training modules featuring patient case scenarios. CDC also released new training and resources for a variety of audiences, including clinicians, patients, family members, friends, and caregivers to promote the importance of naloxone and provide strategies to communicate about naloxone in a non-stigmatizing manner. CDC also worked with the Office of the National Coordinator for Health IT to develop electronic clinical decision support tools for opioid prescribing for electronic health records. And we'd love to connect with you online, so be sure to follow our social media handles that you see here to stay up to date on the latest CDC opioids news and research. Thank you again very much for this opportunity to introduce you to the work we do in DOP, including the 2022 guideline. And now I am happy to answer any questions.
If there are any questions, you can put them in the Q&A box on the bottom of the Zoom link. Thank you for the presentation. It's now open for questions. So we have some questions that are starting to come into the Q&A box. The first question is, do you have any recommendations for alternative non-opioid medications for acute pain? There seem to be limited options.
Yeah, thanks for that question. There, in the guidelines themselves, under the recommendation number 1, it goes into a lot of detail about potential alternatives to opioid therapy, both pharmacologic and non-pharmacologic. So I would encourage you to take a look at the guidelines specifically around that question. And that can give you some ideas about other ways that you could treat acute pain without using opioid medication.
Next question, does the guidelines address co-prescription stimulant use?
It does not, no. The guidelines specifically around opioid prescribing, the one other category of medication that is specifically mentioned is the benzodiazepines and other nervous system depressants, but it does not go into the co-prescription with stimulants.
Are you aware of, next question is, are you aware of any models of care that health systems are implementing to mitigate risks to patients on long-term opioids?
Yeah, there definitely are some health systems around the country that have started trying to implement a variety of different strategies, including kind of having standing orders for naloxone if you're on long-term opioid therapy, involving a more multidisciplinary team has been a very successful model for patients that are on long-term opioid therapy. There's been a variety of different approaches, and I think one of the things that our division is trying to do is really learn as much as we can from the different approaches that health systems and jurisdictions are taking to kind of figure out what are the best practices. And if you wanted specific examples, I can follow up with you by email as well.
Next question was actually in the chat. Where did it go? Does CDC have plan to evaluate how clinicians use or follow the guidelines?
We do actually. We just launched an evaluation project with a contractor that is they're going to be looking both at implementation and impact in a variety of different ways. Some of the evaluation is going to be focus groups and interviews with clinicians to find out exactly how the guidelines have been received, have been understood, and how they're being implemented. So that project has just started within the past month.
Great. That's all the questions that we have right now. If anyone has any questions, they can put them in the Q&A section. Well, seeing no more questions, Dr. Schmit, thank you so much for presenting today. This is a wonderful presentation, and we're glad to have Preventive Medicine Grand Rounds with introducing these updated guidelines, which were, when they came out, they made a lot of news, and now more news came out when they were updated. So an important topic, important work that you do is done for preventive medicine. So thank you. Everyone can join us again for our next Preventive Medicine Grand Rounds. Announcements will be sent out through email and in the consolidated daily announcements about our next Preventive Medicine Grand Rounds. Thank you again, everyone, and enjoy the rest of your day.
Thank you. Appreciate the opportunity.